Hello, my name is Dr. Todd Kopelman. I'm a psychologist. I work in the Department of Psychiatry at the University Hospital in Iowa City, and I'm very excited to have this opportunity to present today. I'm going to be talking about autism and problem behaviors with a particular focus on an approach called applied behavior analysis, or ABA. And I'm also very excited to have this opportunity to share this presentation with one of my dear colleagues, Dr. Matt O'Brien, who is a professor in the Department of Pediatrics at the University Hospital in Iowa City. So jumping right in, kind of the goals for our presentation today are we really hope we can increase your understanding of autism and problem behaviors and the relationship that sometimes does exist, and then increase your familiarity with applied behavior analysis, or ABA, which is an evidence-based approach to try to better understand and effectively treat those behaviors of concern. One important note or caveat before we get into the materials is that this will be a general introduction to autism, problem behaviors, and applied behavior analysis. It's not a certification program. It's not a how to practice training video. So you certainly shouldn't change directly how you interact with any individuals with autism that you work with without appropriate supervision. That said, we do hope that this is helpful and informative. An outline of the talk, I'm going to spend a little bit of time talking about autism and problem behaviors, then introduce you to applied behavior analysis, or ABA, hopefully give you a sense of what it is. Talk about the idea of thinking about behaviors from a functional perspective, which is really at the heart of applied behavior analysis. And then we're going to introduce you to some common treatment approaches or ideas about treatment, again, so that you're familiar with them. Okay, that said, let's get started. I think a good introduction is, I've been using this term already, of problem behaviors. And I'll be honest, that's a pretty general term. So I wanted to start off by trying to define exactly what a problem behavior is as best I can. One definition that I found is that a problem behavior is a behavior that is considered not culturally or socially acceptable, that it puts the physical safety of the individual or others in jeopardy, and that it can negatively impact learning or limit access to community settings and recreational opportunities. A fairly broad definition, but I hope it gives you a sense of the types of behaviors that we're going to be discussing. And I'll go into more detail in just a minute. I do think it's important to point out here, as it says in this definition, that a problem behavior is one that is not culturally or socially acceptable. And that obviously can change over time. You know, I wouldn't be surprised if somebody happened to watch this video in 20 or 30 years, not that I'm expecting that that will happen, but if it did, that the specific behaviors that were considered problem behaviors in the future are a little bit different than they are today, just as our society changes our understanding of what's problematic and what's not. So all of that said, here are some common problem behaviors that as a psychologist, I see in a clinical setting. Self-injurious behavior is certainly one. Physical aggression, severe tantrums, those are probably the most common behaviors that I get referrals for in clinic. Other behaviors that certainly occur, maybe not quite as often, are things like property destruction, what we call non-compliant behavior, elopement or wandering, which can be a major concern, pica, which is the ingestion of inedible objects, rectal digging and fecal smearing. And then I would say certain types of vocalizations. So somebody who maybe from a communication standpoint engages in a lot of repetitive speech, making sounds repetitively or saying only specific words or phrases, which can result in social and communication challenges. Screeching or other loud noises like yelling, and then profanity as well is sometimes considered a problem behavior. And I'm going to highlight from this list, you can see it in red here, just one of these behaviors, because even these terms like self-injury or tantrums, they're pretty general, right? So I wanted to dig down a little bit and give you some examples of how we think about these behaviors when we're seeing them in a clinical setting. So if somebody came in and I heard, from their parent or a loved one or a teacher that this child or adult is displaying self-injury, I would first want to know, what does it look like? And that's called operationalizing the behavior, really trying to understand exactly what a behavior looks like, so that when I see what's called self-injury, everybody else is seeing the same thing. And so I might hear about this individual with autism who is banging their head or biting themselves, scratching themselves, banging their arms, punching themselves. And I could go on here. You can see these are all different examples that fall into this one category called self-injurious behavior. And there certainly are other examples of self-injury here. So that's step one, is we've got these very general terms like self-injury or aggression. But when we're actually evaluating these behaviors, we want to understand in a little bit more detail what they look like. So why are we concerned about problem behaviors? And again, I'm just using self-injury as one example, but this can apply to many other behaviors as well. Well, with self-injury, because of obviously the effects that it could have on the person. It can result in bruising, scarring, infection, concussion, fractions, and so on and so forth. Lots of concerns related to that behavior. That's why we'd consider it problematic. I could have done the same thing with physical aggression. The behaviors are applied more to others than to the individual themselves. Wandering, pica, we want to understand what kind of an effect can those behaviors have on that person or others before we decide if it's problematic or not, and we decide whether or not we need to further evaluate and treat it. So that's always step one, is understanding what the behavior looks like and why we're worried about it. So you can see, and again, just picking on self-injury as one example, why we might be concerned about it. Not only the behavioral effects for the individual, but also longer term concerns. A lot of the problematic behaviors that I see from individuals with autism really are concerning because they reduce that person's opportunities to participate in a meaningful way in their community and in society. So if it's a child, oftentimes I'll see that they have fewer opportunities to be in a regular classroom setting and to interact with other kids at school and in the community. They become more isolated. I see this a lot with adults with more severe problem behaviors. Unfortunately, that they're not able to leave their home, go out to stores and other fun events. And I also see that it can result in opportunities for where that person lives. They may end up spending more of their time in certain types of homes. They may not be able to live in other types of living environments. I've had many individuals I work with who've been kicked out of group homes, or their mom and dad who love them very much can't care for them. And then certainly there's a lot of research, and I see this pretty frequently, that it's a very highly reported result of stress from parents and other caregivers. You as a caregiver yourself may be nodding your head that when you're working with somebody who engages in self-injury or another type of problem behavior, it certainly can be very challenging for you. So I want to talk next about autism and problem behaviors. Important to say from the get-go that many individuals who are diagnosed with autism never engage in problem behaviors at any point in their lives. About 50%, according to some research anyway, of individuals with an autism diagnosis do not display behaviors of concern, those types of problem behaviors. If you look at it the other way, 50% or more, though, do at some point in their life engage in one or more behaviors of significant concern. I would say that that's a pretty high percentage, 50%, and that's a very rough estimate. Depends very much on how problem behaviors are defined and at what point in a lifetime we're looking at those. I've seen statistics up to 90% of individuals with autism engage in problem behaviors at some point. To put that in perspective, the percentage of individuals with autism who engage in the problem behaviors that I mentioned is higher than almost any other population that I'm aware of. So it's higher rates, higher percentage than in persons who have an intellectual disability, who do not have autism, who have language or communication impairments, visual and auditory impairments, seizures, headaches, or who are, and I don't like this term a lot, but typically developing, whatever that means. So it seems like there's something about the diagnosis of autism that puts a person at higher risk for engaging in problem behaviors. Excuse me, I need a little drink there. Another thing to keep in mind is that not always, but oftentimes these behaviors tend to be what we call chronic, meaning that if they occur in childhood, they often do continue well into adulthood, unless appropriate treatments are identified and put in place. So we should not expect, if we see a child with autism who starts to engage in problem behaviors, that we should just let it go because it's going to stop in a few weeks or a few months. I don't think that that's a very effective, although it may be well intended, I don't think it's an effective way to think about those behaviors. So what are some factors that put an individual with an autism diagnosis at risk for displaying problem behaviors? There are several general ones that we've identified. So the types of symptoms, some people use the severity as a term of symptoms, but looking at the research, if somebody has a lot of what we call insistence on sameness, some people call this severe rigidity, just difficulty with changes in their environment and their routine, that seems to be a risk factor. We see a lot of what we call compulsive behaviors. Again, things have to be done just so, that kind of quality to an individual, or a lot of repetitive behaviors. Those, compared to the others, characteristics or symptoms of autism, seem to be putting somebody at heightened risk for problem behaviors. There does seem to be some association, not 100% by any means, but between the degree of cognitive or intellectual impairment and problem behaviors. So persons with autism who have more severe intellectual concerns tend to have higher rates of problem behaviors than those maybe who are in the kind of average to even the superior range cognitively. Again, every case is different though. More concerning communication impairments, and this to me is not at all surprising, but it's good to see in the research, is associated with higher rates of problem behavior. More significant difficulties with social interactions. Also, again, probably makes sense to you that if somebody struggles with engaging with others in their world, that they may be more likely to engage in problem behaviors. Sleep disturbances, motor stereotypies, especially if they emerge early in life before the age of 3, and then an early history of self-injurious behavior. So if we're seeing self-injury emerge in toddlerhood, that can be a red flag for prolonged problem behavior. In other words, that it's more chronic. So I'm going to move from talking about kind of what are problem behaviors and what are the risk factors for individuals with autism to talking about understanding and treatment of problem behaviors. So what do we do? If I'm seeing somebody in my clinic who's referred because they're engaging in these behaviors, aggression or self-injury, the first step is that we want to understand why the behavior is occurring. That's really important before we move to treatment. So assessment first, or evaluation, and then we move to treatment from there. There's some common myths that I hope I can dispel about autism and problem behaviors. So I've heard all of these things before. The first is that, well, this adult or this child is engaging in problem behavior because they have autism. Of course, that's why they do it. It's just part of the diagnosis. Well, I did say just a minute ago that a person with autism is at higher risk for engaging in problem behavior. That doesn't mean that we should expect them to engage in problem behavior, that it's part of the diagnosis itself. It's not. So we need to look at a person and say, yes, they're a person with autism or an autistic individual, and they're engaging in problem behavior. This problem behavior we've determined is causing difficulties for them. So therefore, we're not going to ignore it. We're going to evaluate and treat it. So that's one kind of myth that I see. Another myth is that all behavior is due to biomedical issues. In other words, well, they're acting out, they're aggressive, or they're hurting themselves because they don't feel good. So let's bring them to a medical doctor. That has to be the cause. On the flip side, I've also seen people say, well, they have autism. Again, it can't be a biomedical issue. It must be their autism. So we don't need to bring them to a doctor. Both of those are inaccurate if they're applied to everyone. So we need to look at each person as an individual and try and understand what might be contributing to their behavior. Another myth that I see is that if you ignore a behavior, it'll just go away. You know, let's give it a few weeks or a few months, and I'm sure that they're going to stop biting themselves or hitting others. We don't really need to worry about this, in other words. Let's kind of put it under the covers. No. As I mentioned earlier, these types of problem behaviors tend to persist if they're not effectively treated, so we do not want to ignore them. If you know somebody who's engaging in problem behavior, you want to have them appropriately evaluated. And then another myth is that all behavior is a form of communication. Now, I will grant that I do think about communication and behavior as being, highly related, but I don't think it's fair to say if somebody maybe is engaging in self-injury because they have, and I'm making this up as an example, but severe dental pain, that when they're hitting themselves, they're really trying to communicate. They're probably in distress and that's why they're hurting themselves. Doesn't feel good. I've had dental pain myself and boy, it is nasty. But I don't think about it from a functional standpoint as a clear form of communication in the same way as maybe making a request or talking about an interest. So this is a little picture here. We've got an individual not looking so happy. And let's say he's engaging in a problem behavior. Let's call it aggression. Maybe he's hitting others. And we want to understand, why is this behavior happening? So I've listed some options here or examples of what might be contributing to behavior. And you can see there's a lot of different examples. So starting on the left side with the blue balloon, we know that there are certain genetic syndromes that put an individual at higher risk. That's what we call a behavioral phenotype. So some syndromes, if you see somebody with that profile, they are at higher risk than the general population of engaging in self-injury or another behavior of concern. I don't feel good. I have a physical illness. I'm sick. That can certainly be another cause of problem behaviors. Sometimes the medication itself can cause problem behaviors. We're trying to treat something with a medication, but there can be side effects. And certainly that's where follow-up with a medical provider is very appropriate. I have a psychiatric illness, depression, for example, or severe anxiety, ADHD. Those can all be related to problem behaviors. I have a skill deficit. I don't know how to interact, how to maybe socially interact in a certain setting. I need help with that. You need to teach me what to do appropriately. And because I don't know from a skills point of view what to do, I may engage in problem behaviors. I'm going to move on now. Those are all possible examples, but I'm going to talk about what I see as a psychologist who practices applied behavior analysis. These next ones are more in my wheelhouse professionally. I want something. We call that a tangible function. We'll talk more about that in a few minutes. I don't want something. I don't want to do maybe a work task or something I'm being asked to do around the house, a chore. And so I engage in problem behavior. You're ignoring me. You're not giving me the amount and the type of attention that I really like. So I'm going to start engaging in problem behavior. That's called an attention function. The final little balloon there at the bottom is what we call a non-social behavior. In other words, there's something internal in me. I don't feel good, or when I hit myself or bite myself, it actually does release something that, chemically that makes me feel good. So that could be another reason. So the take home from this slide here is that there can be a lot of reasons why an individual might engage in behaviors of concern. And we need to think very kind of comprehensively or thoroughly about what's going on for that individual before we treat. I'm going to talk very briefly in more detail about some of those examples, but the main focus, as I mentioned earlier, is on ABA. So certainly physical illness is something that needs to be ruled out, and that should be ruled out first. So there are several studies that have been published indicating that if somebody is engaging in problem behavior, it could be secondary to an undiagnosed medical condition and or side effects from a medication that they're taking. It is important to keep in mind for some individuals with autism that they may feel pain in the same way that you or I do, but they may not show it in the same way. And that can be related to communication challenges. So we cannot always rely on somebody's verbal self-report to tell you, hey, you know what, I'm hitting myself because my tooth hurts. So can you bring me to the dentist? They may not have the communication skills to do that. So again, they may just start to bite themselves or engage in other behaviors of concern. So we as care providers sometimes need to almost be detectives and say, this is a change in how this person typically interacts. We need to look at them medically and get this ruled out. So as it says here in the slide, I oftentimes want to know how often or how long this behavior has been occurring. And if it's a sudden change from how a person usually interacts and behaves, if I hear that usually this person's pretty mellow, but about 2 weeks ago, they started to really become agitated, and bite themselves or lash out, become aggressive, then, first step is let's bring them to a doctor. So these are just some of the common physical illnesses or issues that we see at the University of Iowa for individuals on the autism spectrum, where again, it's a medical issue and not something what we call environmental. So GI issues, seizures, dental issues, as I've brought up, fractures, pneumonia, COVID, and hearing and visual impairments, all can cause problem behaviors. There are certain genetic disorders, and I'm not going to go through these in a lot of detail in this talk, but do want you to be aware of that. If somebody has one of these genetic disorders or syndromes, that does not typically mean that they are going to engage in problem behavior, but it can be a risk factor for certain types of problem behaviors. So I'll leave that up there for just a minute so you can see it. So it's important to know somebody's medical history when you're working with them. So with that, I'm going to move to another topic, which is evidence-based interventions for autism. So why should we even consider evidence-based interventions, such as applied behavior analysis? Well, the scientist in me says, because we want better outcomes on a practical level, right? We want to know what works from an assessment and a treatment standpoint so that we can best help our client or our loved one. It's a lot more efficient typically if you start with what's known to work, right? Otherwise, you may try a lot of different approaches and be hopeful that they're going to be effective, but you may not know because there's not a lot of research to support them as an evidence-based treatment. So related to being efficient, it can save a lot of money and other resources, especially time. So I certainly have worked with patients who have tried a lot of different treatments for several months because they were hopeful. They'd heard from maybe other people anecdotally that it helped another person or child, but they weren't evidence-based approaches and unfortunately did not have the intended positive effects. So they put a lot of resources and time into it, and then they ended up in the same place that they probably should have started. A really important, I think, mantra, it's more than that, it's kind of something that we should live by professionally, is that step one is to not do harm, right? You've probably heard that before when you're working with a patient or a consumer, a client, however you refer to somebody, you want to do no harm. You want to help them, most importantly, but more important than that even is not to harm. And then I think ethically, we have a responsibility as clinicians, especially, to provide care that is based on research. In other words, if somebody is coming to me as a psychologist, or they're coming to one of my colleagues who's, let's say, a physician, they're going to them because they're trusting that as a professional, we know what we're doing. We're competent. We're basing our guidance, our recommendations on research. How do we know if something is evidence-based, especially in the area of autism? We are very fortunate that there has been a lot of research conducted in the area of evidence-based treatments for problem behaviors for persons who are autistic or who have autism. And there have been some nice collections of research, reviews of research that have been done over the last 10 or 15 years. And so on this slide, you can see some examples of where you can go yourself if you're interested to look at the research. So don't just trust me, but feel free to look at these, what we call kind of analyses or meta-analyses of research. In other words, looking at all the research that's been published, having guidelines for deciding what makes quality research, how was the research conducted, and then determining whether or not certain approaches reach that high threshold of being evidence-based. So again, you could look at the National Autism Center, which has, the website is listed here. They have a nice kind of collection of what is evidence-based at this time. University of North Carolina Child Development Institute has similar information, and the National Professional Development Center on Autism Spectrum Disorders. So again, it's very transparent, which I like. You can look at their methodology that they used, how they decided which studies to include, how they evaluated the different studies, what the criteria were, and then finally, which studies met that high bar for being considered empirically supported or evidence-based. And at this point, I'm going to get to applied behavior analysis, or ABA. So if you look at autism treatments in some of those reviews, you will see that the majority of treatments right now that are considered evidence-based utilize ABA, or applied behavior analysis, as a core part of their methodology. So 36 of 42 evidence-based treatments or empirically supported treatments utilize ABA as one of the core components, and 17 of the 42 are exclusively based on ABA. So ABA, kind of the bottom line summary here, is it informs a lot of what we know about evidence-based treatments. So does ABA work? Is it effective for decreasing problem behaviors? The answer, and this is a pretty clear answer, is that in most cases, it is yes, it is effective. So I've listed some studies here that have found on average in studies that are published that there's an 80 to 90% reduction in the behavior of concern utilizing ABA approaches. And so other studies cited here have found that what we call function-based behavioral treatments are effective in reducing behaviors in the vast majority of cases. Okay, so I am going to stop there and turn it over to my colleague, Dr. Matt O'Brien.